Can you see my slides?
Yes, it's actually crystal clear.
Great. Okay, good. So today we are going to continue our talk about hyperglycemic emergencies. Previously we talked about DKA and hyperglycemic hyperosmolar state is in a way a continuation of this condition and cannot be fully separated. There are differences and there are areas where they can meet together. So we are going to talk about this and discuss the situations where you see both at the same time. The objectives from the learning objectives from our lecture today will be focused about understanding the condition and how it develops, and then identify the precipitating factors, and then understand how to approach this and how to manage it, and what are the key factors that you need to consider when you see such patients in order to reverse the HHS. And during management, of course, there will be some complications. So you need to be aware how to address these complications and how to prevent them. And then we will touch base on HHS in special situations like heart failure, chronic kidney disease, pediatrics, and those with mixed HHS and DKA. And at the end, we are going to have case-based discussions. I have 4 cases for you, but if you feel tired at any point and you want me to end the talk, please don't hesitate to ask for this. And during the presentation, if anyone wants to unmute and ask a question, by all means, go ahead and do that. The presentation today is mainly derived from these 2 guidelines. The initial one is the consensus guideline, which is published in 2024. That is a consensus that involves the American, British, and European guidelines, which is the latest published so far. And I also took some information from the British or the Joint British Diabetes Society inpatient care guidelines. So these are the 2 sources if you want to go back and read about it in details. As previously shared, HHS carries a high burden on the inpatient care with the highest mortality rate compared to DKA, up to 10 times more mortality compared to DKA. And the majority of the cases are seen, of course, in elderly, but nowadays we are seeing patients who are younger, and pediatric patients are also developing this condition and as part of the hyperglycemic emergency. 60% of the precipitants are infection, but there are other precipitants that we need to keep in mind. And almost 1/3 of the patients who present with HHS are found to be that this is the first presentation of diabetes. There is a high mortality noted in those with the mixed DKA and HHS, and less so seen among those with pure HHS and pure DKA. Good. First of all, we need to understand, in order to understand HHS, we need to understand the concept of osmolality and the movement of fluids between the intracellular space and extracellular space. So normally there will be a balance or osmotic balance between the extracellular fluid and intracellular fluid, and this is maintained through the movement of the osmoles or the electrolytes between these 2 spaces. In situations when you have hyperglycemia in the extracellular space, fluid will shift from the intracellular space to the extracellular space in order to balance the osmotic equilibrium to maintain as normal osmolality as possible. And as you can see, the intracellular fluid in the early stages is slightly reduced in order to maintain normal osmotic gradient between it and the extracellular fluid. But when the hyperglycemia continues and it's unmanaged, or when there's a delayed hydration or delayed correction of whatever the reason that led to increased osmolality in the extracellular fluid, this will lead to further shift of the fluid or from the intracellular space to the extracellular space in order to maintain this osmotic equilibrium. But with the impact of the osmotic diuresis and the fact that the patient, for example, not replacing that lost fluid, this fluid will not, this shift of fluid from the intracellular space will not be able to maintain normal osmolality or a normal balance between the two spaces. And there will be a drop of the intracellular fluid, which is shifting out of it to correct the extracellular fluid, which is already getting worse and worse without any intervention. As this process continues, the patient will end up having a severe form of dehydration or fluid loss intracellularly as well as extracellularly. Okay, so this is the main principle of HHS and how the fluid loss happens. And the longer the situation, the worse the dehydration and the fluid loss between the two spaces. So in HHS, you must have the triad, a triad of having hyperglycemia, that precipitates dehydration through osmotic diuresis, and subsequently the two elements will lead to high osmolality. And we understood now how high osmolality happens from the previous slide. So before we go into the further into this, we just need to understand the precipitant factors that lead to high HHS. Most of the factors are similar to the ones we see in DKA, infection, any type of stress, whether this is infection or a macrovascular or cardiovascular event that led to an increase in the counter-regulatory hormones and subsequently hyperglycemia, or iatrogenic medications induced, most importantly, the steroids that lead to high insulin resistance and increased hepatic gluconeogenesis, diuretics through the impact on fluid loss, as well as antipsychotics that increase the insulin, that reduce insulin sensitivity, and SGLT2 inhibitors through dehydration, and as well as phenytoin, diazoxide, methadone, and beta blockers through various mechanisms, from reduced insulin sensitivity to hyperglycemia to increased resistance. Most of presentations with HHS is seen among elderly patients who have impaired the thirst mechanism, and they already have multi-organ failure at that age, where they have renal failure and impaired fluid balance, and some of them have dementia, where they have they are unable to express the thirst sensation properly, and they lack the adequate monitoring. Also seen among patients who have a limited access to water for various reasons, whether they're social reasons, deprivation, etc. And as we said earlier, a third of the patients are present with HHS as the first presentation of their diabetes. Okay, so this diagram just explains the process of HHS. So as we said, the event starts with a precipitating factor, whether it's infection, cardiovascular event, or drug-induced, whatever precipitant it is. When there is this precipitant, there is a stress that leads to increase in counter-regulatory hormones we talked about in our last meeting, namely glucagon, cortisol, catecholamines, as well as growth hormone. And all of them jointly increase glucose production in order to produce the energy needed to meet the stress. This happens in a background of relative insulin deficiency because HHS patients have enough insulin in their system that would be able to prevent ketone body production, but unable to process the high glucose load that's happening due to that stress. Then this high glucose intravascular or hyperglycemia, as we said, will lead to saturation of the renal tubules, osmotic diuresis, and dehydration that subsequently leads to deranged electrolytes and acute kidney injury. This increased urinary fluid losses alongside the impaired thirst sensation in those patients with impaired ADH secretion, which is seen in elderly, all combined lead to massive fluid losses. And at the time of presentation, those patients tend to have up to 10 liters of fluid deficit. This happens, this dehydration will impact on the ability, the mental their mental status, and it will lead to confusion and subsequently, in some patients with severe cases, coma. And the old name of HHS was hyperosmolar hyperketotic state or coma, which has changed in the past few years. Um, this severe dehydration and fluid loss will also lead to muscles injury and increased risk of rhabdomyolysis. And this will even exacerbate the acute kidney injury seen in those patients and electrolyte disturbances seen in such patients. And this combination of high osmolality, dehydration, and they tend to be immobile will increase the risk of venous thromboembolism. Is it all clear so far? Good. So going further from that pathophysiology slide, we come to the diagnostic criteria, which you see, which is in the latest published consensus guidelines. So in order to diagnose HHS, you need all of the criteria mentioned in this table. You need a hyperglycemia, blood sugar above 600 and above. You need hyperosmolality, whether this hyperosmolality you calculated as the effective one without considering urea or the total one when you add urea. And we will talk about that more in details. And then you need to have normal ketones or mildly raised ketones. So ketones, positive ketones will not be pure HHS. You will need to consider the mixed picture here. But for HHS, beta hydroxybutyrate or ketone should be below 3 and urinary ketones below 2 plus, and pH should be above 7.3. So the 7.3 numbers for the pH and the beta hydroxybutyrate below 3, these are the cutoffs we see in DKA, because in DKA, if you remember, we said ketones above 3 and pH below 7.3. Okay, it's important to remember again, and I emphasize on this again, that dehydration and hyperglycemia are required to diagnose HHS. And this dehydration manifests either as elevated urea or hypernatremia. In the old guidelines, mental status confusion was part of the criteria, but they have removed it now in order to increase the diagnostic sensitivity in this for such cases. Severe HHS a patient is considered to have severe HHS when their osmolality is above 350, sodium above 160, acidotic with a pH below 7.1. They have reduced GCS. They have abnormal potassium, whether extremely low or high, and they are hemodynamically unstable. They have renal shutdown with oliguria and AKI, severe AKI, and they are hypoxic with a background precipitate being a macrovascular event. So anyone with such criteria is considered to have severe HHS, and they cannot be managed in normal setting, and they need higher care settings, whether it's HDU or ICU. All right, shall I proceed? Any questions so far? Fine,
Oh, clear, Dr. Zainab.
thank you. Okay,
Nothing in the chat.
so when we talked about the triad, we talked about hyperglycemia, dehydration, and high osmolality. All these are needed in order to diagnose DKA. So, and in addition to having the precipitant event that led to it. So your goal is to normalize hyperglycemia. The second goal is to replace the fluids and to normalize osmolality. In addition to that, your main goal as well is to identify and treat the precipitating factor, the event. Whatever that event is, you need to identify it. So the initial goals should be the four we mentioned here. And while you are treating the HHS, you need to avoid the complications that come with it, namely venous thromboembolism. So patients should be adequately checked for signs of VTE, and prevention or prophylaxis should be prescribed. And they should have their feet inspected and checked because they are at high risk of developing feet ulcers. And then they should also have a regular neuro observation because they are at high risk of developing cerebral complications, whether it's cerebral edema or osmotic demyelination, or even they can develop stroke late during inpatient that may not have developed before that, but the precipitant event or whatever, when they are inpatient, stroke could develop. So these are should be your aims, and what you should avoid while you are managing those critically ill patients. Good. So the key principles in managing HHS now, because we said the aim is to normalize sugars, hydrate, and normalize osmolality. So the key principles would be different from DKA. In DKA, if you remember, we said there is an acidosis, and the only thing that would switch ketone body production is the introduction of insulin. So insulin should be introduced yearly in DKA. Unlike HHS, though, the HHS fluids come first because osmolality is our main problem. We know those patients are extremely dry at the time of presentation, and that HHS will be the main driver here is the high blood sugar. So the cornerstone here is to resuscitate with the fluid to restore the intravascular volume, improve renal perfusion, and improve osmolality, which would subsequently improve the rest of the parameters that we are having. Insulin here is not a primary goal, not a primary approach in the management. It should be a secondary one when your initial approach or the fluid approach fails to improve osmolality or reduce blood sugars. You only introduce insulin yearly when you have evidence of acidosis in the mixed DKA and HHS. So fluid comes first, insulin is secondary and not a primary approach here. In addition to that, you need to aim for a gradual decline in osmolality to prevent the complication that happens from rapid shift in osmotic pressure between the intracellular and extracellular spaces. And then this happens through gradual correction of osmolality that we will talk about in our presentation later on. Good. I presented this slide in my previous talk in the DKA, and I'm presenting it here again just to show you that how fluids can remarkably improve hyperglycemia. That's why in the hyperglycemic crises or emergencies, at the time of arrival, at the time you see the patients, give them fluid bolus. You will notice a rapid drop in blood sugars in those patients. So and HHS are quite fluid responsive. They tend to be fluid responsive, especially when they don't have DKA or acidosis. Fine. So the fluid protocol in HHS patients. So this applies to the standard patient who does not have comorbidities and does not have any contraindication to have fluid as per protocol. So the standard is to give 500 to 1 liter in the first hour, and then subsequently you follow that by ongoing fluids, 1 liter every 2 hours, and then 4 hours, and then 6 hours, and so on. There is a protocol, you just need to follow it. Your aim is to use the main fluid to use is normal saline, and that normal saline is effective. It's cheap and it's available everywhere, and it shows good response. Patients do show good response on it. The fluid speed, you don't have to stick to the protocol. You can give it faster if your patient is hemodynamically unstable. You can give it slower if you feel the patient is at risk of having overload. At the time of presentation, so the initial thing you do, you get an IV A to E assessment, just like any medical emergency. You gain an IV access. You take initial bloods, electrolytes, ECG, cultures to look for precipitant event, and you give, of course, the fluid, the initial resuscitative fluids. Subsequently, you continue with your IV fluids, and your target in the first 6 hours is to have 2 to 3 liters positive balance. So urine output monitoring is essential in those patients in order to calculate the fluid balance. And then while you are delivering fluids, you need to regularly check blood sugars on hourly basis, calculate osmolality, and then check as well ketones in case patient become acidotic during the management. The aim for your blood sugars is to drop by 90 milligrams per deciliter per hour. And if you feel that the sugar is not responding to your initial fluid and the osmolality is not shifting, that's when you start the insulin, but not before that. After you started the initial resuscitation with normal saline, you do not need to introduce half saline in all cases. We only introduce it when we feel that the sodium is not dropping and the osmolality is not shifting. So your marker is not only the sodium, your main marker is the osmolality. Following that, we continue with the fluid replacement, we continue with the monitoring, we continue with the regular sugar check, fluid balance, osmolality, and then while we are doing that, we continue to manage the precipitating events, and then we prevent the complications we talked about earlier in terms of foot ulcers, VTE, and correct any electrolytes. So this is just the main outline of how to manage HHS. Talking into further details about this management. So the fluid, as we said, the primary fluid is normal saline, and we only use half saline if osmolality is not falling, despite adequate positive balance. So this is important. You can't just calculate the osmolality and then you say osmolality is not falling, but the patient is actually in negative balance and they haven't received enough fluids. So this is very important. They go hand in hand together. And the target, as we said, the glucose to fall 90 milligrams per deciliter per hour, or sodium should not be falling more than 10 millimole in 24 hours to avoid cerebral complications. Insulin is not introduced unless there is no changes in osmolality or if the patient becomes ketotic, i.e. if capillary ketones are more than 1 and less than 3 despite fluid management. And at this case, you start at half the rate you start for the DKA patients. But if the patient is meeting DKA criteria, i.e. ketones more than 3, or urine ketones more than 2 plus, then you start as per DKA protocol with the insulin infusion dose. Okay. If the patient is already on basal insulin, do not stop it. Just continue that. We correct electrolyte as we do with the DKA. If potassium is low, we have to replace before starting insulin. If it's high, we have to manage. And then we continue to monitor that as usual. Just need to keep in mind as we manage HHS, there will be, if you are resuscitating with the fluids appropriately, as sugar drops, there will be an initial rise in sodium, which you should not panic, as long as this rise is not exceeding 2.4 or 2.5 millimole per liter. This is a common finding. You see it because of the changes in the osmolality of the intravascular fluid. So as we said, so your marker when you switch to half saline is not only sodium, it's the sodium and the osmolality. These are the two things that you need to keep in mind, as well as your fluid balance. So having a rise in sodium with a drop in osmolality is not a signal for you to start hypotonic solution. And again, we keep talking about this, VTE prophylaxis is essential. So these are the essential management outlines in HHS. This is derived from the British guidelines. Again, it's just the same protocol again. I just wanted to highlight the osmolality changes during while you are treating. So you initially, as we said, you start with your fluid bolus and you continue with the fluid in the first 6 to 12 hours. And while you're doing that, you continue to monitor sugars hourly. You can calculate osmolality and you monitor your urine output and the fluid balance. So if you notice that the osmolality is increasing, what you need to check, first of all, you need to check if your fluid balance is adequate or not. If it's adequate and the osmolality is going up, that's when you switch to half saline. But if your osmolality is going up, but you have a negative balance, then you have not hydrated the patient well between 5 and 8 between 5 and 8 sorry, between 3 and 8. So if it's going slower than the rate recommended by the guidelines, which is below 3 milliosmol per kg per hour, that's when you need to again go back and review your fluid balance. Are you adequately hydrating or not? So if the osmolality is going down slowly and your sodium is going up, and the patient is having negative balance, then you need to increase the rate of infusion. That means you have not hydrated the patient well. If the osmolality is decreasing at appropriate level and the sodium is going up, but the rate of osmolality is going as recommended, 3 to 8 milliosmol per kg, that's when you need to continue with the same sodium chloride fluid you are giving at the same rate. That means whatever you're doing is right, and this rise in sodium is not concerning. It's just an initial rise, as the one we talked about, as osmolality drops and as sugar drops. And lastly, when the osmolality is going too fast, very quickly, that's when you need to reduce your infusion fluid rate and or stop insulin if the patient being started on insulin. As we said, we don't want a rapid change in osmolality and we don't want a slow change in osmolality. We want a balanced change, a balanced reduction, a slow reduction to allow the brain cells to accommodate this change in osmolality and change in the pressure between the intra and extravascular fluid in order to avoid any disruption and rupture to the membrane and the neuronal sheath, which will lead to either cerebral edema or osmotic demyelination syndrome. Good. On the other hand, with the blood sugars, when you feel the sugars are not Again, just the same applies to the blood sugars. So when the sugars are not responding well to fluids, you need to increase the rate of infusion. And if the patient is underfilled, if they are adequately filled, then that's when you need to start the fixed rate insulin infusion. Okay. And then if the sugars are going down too fast, that means they will change the osmolality very quickly. That's when you need to reduce your infusion rate or slow down the insulin or stop it. Any questions so far? I know it's a lot of numbers and a lot of things to keep an eye on, but I find this chart very useful. When you see such patients, just look at this chart and manage accordingly. But I'm happy to answer any question if anyone has any.
Yeah, thank you so much, Dr. Zainab. It's actually crystal clear. But I have a question actually. What to do if my patient has a heart failure? We know
Yes,
that there is a lot. Yes, there's this fluid gush that it's needed to be adequate to in order to treat it. This
we have a
HHS. So how we are managing this
we have a
part of this?
dedicated slide for heart failure. I'll talk about it
Oh,
later.
okay. So we have this special consideration.
Yes, yeah.
Um,
Any other
I
questions?
think we have a question here from Dr. Jafar Ihsan. He thanks you so much. So, due to risk of hyperchloremic acidosis, I'm presuming that the patient may benefit more of having ringer lactate instead of saline solution.
It's the same. I mean, the same as per DKA. We talked about this last time.
Yes.
So, studies are there showing that patients are showing good response to ringer lactate, but it has not been. These are all observational studies. Nothing has been fully published or approved yet. And normal saline with the rates and the volumes we are delivering in such patients did not really show any high risk of having hyperchloremic acidosis. But by all means, if what you have is ringer lactate, then use it, but it's not recommended yet. And every guideline, whether European, American, or British, are recommending soma saline because it's safe, it's widely available, and no real complications were found with it.
Okay. So, Dr. Jafar, again, can we start half normal saline early on if it indicated? So to say in the second hour?
When you say indicated, second hour is too early. You haven't really resuscitated well. So it's too soon because this will lead to a rapid shift in osmolality, which is dangerous. We need to slow down. We need to slowly reduce things. We don't should not rush to change the osmolality or sodium. So it just feels too early in the second hour to start half no half saline, which may lead to dangerous consequences.
Yes, the doctor. So you can go ahead.
Yeah. Good. This slide just shows you a comparison between HHS and DKA. So HHS patients, the main thing, as we said, is the hyperosmolality, hyperglycemia, osmotic diuresis that leads to dehydration and subsequently the consequences of that dehydration. While in HHS and DKA, the acidosis and ketone body production that results from fat breakdown are the main problem and the main threat, alongside, of course, dehydration and hyperglycemia, but it's mainly the acidosis. But there is the DKA HHS overlap syndrome where you see patients with hyperglycemia, extremely dry, but at the same time, they meet the DKA criteria in terms of having acidosis with a low pH of below 7.3, bicarbs below 18, and ketones, as we talked earlier, above 3 capillary plasma or urine above 2 plus. I have a question for the audience. Why is hyperosmolality usually not the dominant issue in DKA, but a major problem in HHS? Any answers?
So they're all, you are feel free to unmute yourself if you want to answer directly. So, and we have an answer from Dr. Ahmed. He thinks because of very high level of glucose in HHS.
Yes. Any other causes?
Dr. Rose had, okay, no, it's just, has a question.
Okay.
Okay, another question, please. Yes. Dr. Jafar, in HHS, it takes a long time for the hyperosmolarity to cause the severe dehydration. And thus complications in HHS, there is still some insulin available to stop ketogenesis.
Yes, in a way, this is correct. So basically, as we said, and ketoacidosis drives earlier presentation. Patients become quite unwell early on because of the acid buildup. While, as we said earlier, HHS takes a long time to develop compared to DKA. So by the time they present, they are extremely dry. They have high osmolality numbers compared to DKA. And that's why hyperosmolality or dehydration is the main problem in HHS, alongside the fact that they have a background insulin that's shutting down the ketone body production. Okay, good. How do we know HHS sorry resolved? HHS resolves when you reverse the issues that the patient presented with, namely osmolality below 300 or normal osmolality, normal or slightly elevated blood sugars, adequate urine output, recovery of the baseline mental status, as well as stable patient who's able to eat and drink if their baseline was that they were able to eat and drink. And we have treated the trigger and corrected electrolyte abnormalities. Okay. Now we talk about the heart failure or the HHS in special situations. So as we understand now, in HHS, the problem is extreme dehydration and high osmolality, and your goal is to hydrate, hydrate, and hydrate. And your main treatment is fluids, 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 and then you give something else like insulin or whatever. But most HHS reverse adequately with just normal saline and adequate hydration. The problem with heart failure, they have diastolic dysfunction, and they tend to be elderly, comorbid, and frail patients. So flooding them with large amounts of fluid, like we give for normal patients, if you follow the standard protocol, would be very dangerous, and they would be at high risk of having pulmonary edema and fluid overload. So those patients should be treated very, very cautiously with a small fluid boluses, and you should not follow the HHS protocol that you follow for the standard patient. So in those patients, we, instead of giving 1 liter in the first hour, we give 250 ml boluses and assess. Regularly give the small boluses and assess their blood pressure, assess the urine output, recheck their sugars, and calculate osmolarities. And these measures or these factors will be your guide in order to decide whether I need to give another bolus or not, or I should wait. Whether this bolus, and you just continue by 250 mils and regularly assess. And the assessment as well includes examining the patients, check their oxygen saturation, examining their chest, and measure their JVP. The fluid rate, as we said, it's 250 to 500 mils per hour, not the standard 1 liter. And your target, instead of having 6 liters in the first 12 hours, your target is 2 to 3 liters positive. But these are just arbitrary numbers. You don't have to follow them. You are guided by your patients, their clinical state, and the severity of their heart failure, and how they respond to whatever bolus you're delivering. The fluid type again is the same standard fluid type, normal saline, and we should not give hypotonic early on because of the risk of pulmonary edema becomes higher because of the tonicity, rapid change in osmolality and tonicity. The monitoring, we talked about how to monitor. If you feel the patient becomes overloaded, you need to diurese. Don't aggressively diurese them. Just give them small doses of IV furosemide and again reassess. It's all about doing things slowly, cautiously, with regular reassessment. And again, you introduce insulin only when the same applies here, when osmolality is not falling and the glucose is not changing despite adequate fluid hydration. Okay? Those patients are they tend to be even more ill and have higher morbidity and mortality compared to the standard HHS patients. So they should be admitted to high dependency area and the cardiologist should be involved early. You should look for a precipitant in those patients, not only an infection, it could be a cardiovascular event. So their troponin should be checked, their proBNP for heart failure should be checked on admission, a chest x-ray should be checked as well. And if you feel they become crackly or require oxygen while you're managing, you need to repeat that chest x-ray to look for signs of pulmonary edema. And if the blood pressure is not responding despite adequate hydration that's suitable for that patient, then inotropes should be considered after discussing with cardiology. So in heart failure, the key principle is to modify the fluid plan, but that does not mean you have to stop the fluid. You just need to modify it and cautiously administer it by using small boluses and regularly monitoring. Does this answer your question, Qasim, regarding heart failure?
It's not clear, Doctora. Thank you so much.
Any question? Right. Okay, so we'll talk about the other special consideration or other special situation, which is the renal failure patients. So those renal patients they have reduced renal ability to deal with the fluids and manage electrolytes as well as osmoles. So they have a blunted glucosuria or blunted response to osmotic diuresis, as you see with normal kidneys, which means the glucose is not secreted in high volumes as in patients with normal kidneys. So higher levels of hyperglycemia is seen in such patients, and they respond slowly to fluids. The fluids, like glucose, falls much slower compared to normal patients because of the longer time required to restore whatever left from that kidney to perfuse that with the fluid. So the HHS resolution takes longer compared to normal patients. And the other problem is they have higher risk of hyperkalemia because of, again, impaired potassium excretion. So it's essential to monitor hyperkalemia in those patients, potassium in those patients. And if you need insulin, like we do for some HHS patients, if you need to introduce insulin, you should delay that until you correct the hypokalemia if you see it. Okay. Fluid balance is essential, like it is for all patients, but you need to keep in mind that the patient, if they are already oliguric, and they may become even more oliguric because of acute kidney injury. So there is a higher risk of fluid overload in those patients, especially if you aggressively manage them with HHS fluids. So cautious IV fluids here is essential, just like in heart failure patient. So monitoring with the JVP, oxygen saturation, regular blood check to look at the creatinine trend, the sodium levels, measuring osmolality is essential. And you cannot rely only on you cannot rely on urine output in those patients because it may be even with adequate hydration, the urine output may still be low because of acute kidney injury on a background of chronic kidney disease. So CKD patients tend to have already high urea. So in order to avoid having falsely elevated osmolality and you wrongly treat patients with the fluids that they do not need, urea is not included in the calculation. So the normal formula that we use to calculate osmolality is having 2 sodium plus glucose plus urea. But in patients with renal failure, there is the effective osmolality, which only includes sodium and glucose and urea. You don't have to include it in this calculation. Um, of course, if they are on any medications that's nephrotoxic or they may lead to complications like metformin that leads to lactic acidosis, you need to stop it and introduce later on if the EGFR is safe to do that. And they like any other patient, they will require VTE prophylaxis, but you need to choose your anticoagulation based on the EGFR level. Those patients at high risk again for fluid overload. So renal team should be involved early, and they may need hemofiltration to remove excess fluids and correct electrolytes if they are resistant to medical management. All right. Before we move to the next special situation, any question?
Thank you so much, dear doctor. Yes, we have Dr. Jafar here. He actually asked, I think most patients with HHS have some level of AKI,
Yes.
especially pre-renal AKI. Does that mean in all of them we must use the effective osmolality formula? Or it
No,
has,
because you need to know what's their baseline. So what's the baseline renal function? If they used to have normal kidney function and then they developed AKI because of HHS, then you just calculate it all. But if someone is known to have chronic kidney disease, so you know their osmolality is already, their urea is already elevated. So incorporating it into the formula will give you will give you an accurate estimation of the current osmolality status. And I mean, if you do the calculation, urea doesn't really contribute that much to the osmolality. It's mainly the sodium that's the main contributor because you have 2 sodium molecules and the glucose. And urea is just adds a small additional number benefit to the formula, especially in CKD patients. So if someone is known to have CKD or renal failure, no, I wouldn't include it. I will calculate the effective osmolality by excluding the urea.
yes, it's crystal clear. So, dear doctor, what about antithrombotic? Yes, we know that we must give it in all patients with HHS, but what about DKAs? When do we have to administer heparin or low
Same,
molecular weight heparin?
same, you have to give it to them as well. Yeah, we
So
have
in
to.
every
Yeah.
patient with DKA, with this one that I will hospitalize him, that I need to give him
So
low molecular weight
any
heparin.
I mean
Yeah.
the guidelines, general inpatient admissions, all of them require VTE prophylaxis
Mm.
unless it's contraindicated, whether it's DKA, HHS, sepsis, infection, they
Yes,
require unless it's
mm.
contraindicated.
I mean, dear doctor, we have a formula that we are use in our daily practice, which is called a PADWA score. I don't know if any of audience are familiar with, but it is found in MedCalc and found in a lot of websites. Its name is PADWA score, PADUA and the score. It's calculated 10 variants in every hospitalized patient that is need to be give a VTA prophylaxis. So what I mean, so do we have a criteria? Do you have a criteria in UK that to deal with such a thing, or you give all the patient or hospitalized patients that we are at risk of VTA prophylaxis,
I mean,
regardless the
there
formula
is
or
a
regardless.
I mean, whatever VTE prophylaxis, the way we do it is just there's a form you fill in, and usually the form excludes VTE prophylaxis in those at high risk of bleeding if they are admitted with bleeding or they are already on anticoagulation. But generally, anyone else who's not in this category, they will receive anticoagulation
Yes.
based
Thank you.
on their renal function and their body weight, of course.
Of course.
And if they do, if they can't have the heparin, then if it's contraindicated, then we need to give the stockings, the TE, the TED stockings, which is another
Yes.
form of mechanical prophylaxis. So prophylaxis should always be there. Yes.
Yes. Thank you. Thank you so much.
Yeah. Now, HHS in pediatrics patient. So this is an emerging thing. It wasn't recognized in the past, but in the recent years, this is a developing problem in this age group. And this is mainly because of higher incidence of obesity and type 2 diabetes in those patients, but it's also seen in type 1 with inadequate insulin treatment or cystic fibrosis patients, and even seen in infants with neonatal diabetes or those on steroids and antipsychotic agents. And it carries a very, very high mortality and morbidity compared to DKA. And they tend to have a higher rate of treatment-related complications compared to the adult HHS patients. And the mixed HHS DKA is very common in pediatric patients. Um, so the approach in this age group is a bit more aggressive in terms of resuscitation because they tend to be quite extremely volume deplete, and given the high mortality and the need to reverse that. So for DKA, the protocol says to give 10 to 20 mils per kg per hour to resuscitate. But for HHS, the ISPAD guidelines recommend giving 20 or more mils per kg per hour of normal saline. And because they found that those patients who present with HHS tend to have 12 to 15% deficit, fluid deficit, compared to non-DKA patients. So that you give this higher, you give this higher bolus of fluids, and again, regularly reassess. There's a strong emphasis on reassessment while you are hydrating or managing such patients. And the aim in HHS in children is to slowly reduce osmolality, even slower compared to adult patients because of the high sensitivity to and high risk of cerebral complications compared to adult patients. So we need to ensure that osmolality is not rapidly changing. So the sodium concentration, the aim is to drop by 0.5 millimole per hour, and the sugar should not be more than 50 milligrams per deciliter per hour. And if you need to introduce insulin, you would introduce a smaller dose of insulin, which is less than that you start for the adults. And if need be, you can go to the 0.5, but you can start with even half of that for children and then regularly reassess. In adults, we say the aim for osmolality to drop 3 to 8 milliosmol per kg per hour. There is no a recommended rate of osmolality in pediatric age groups. There is a literature review suggesting less than 3 milliosmol per kg per hour, but there's nothing mentioned in the guidelines regarding that. The focus is on the sodium drop and the sugar drop, not the osmolality, the rate of osmolality per hour. The HHS guidelines in children is still not because we said it's a new thing in this age group emerging in the past few years. So most of the recommendations are based on observations on cases seen or admitted in hospital, and most of it as well is derived from the adult guidelines with some modifications to suit the children, the pediatric age group. The issue with the pediatric HHS is higher risk of VTE. So if the patient is 12 years or older, they should receive VTE prophylaxis. There's a high risk of rhabdomyolysis compared to the adult age group. So creatinine kinase should be monitored. There is a high risk of developing malignant hyperthermia syndrome, which is not known why it happens in those patients when they become hyperthermic with elevated CK and deranged electrolytes, and it carries a high mortality, even when you treat it with the dantrolene, there is still a very high risk of mortality risk. Cerebral edema is very high in those patients. So regular neurological observation every 30 minutes, and you need to act immediately to reverse the cerebral edema if it happens with either hypertonic saline or mannitol. Any question before we go to the cases? Fine. Okay. So just before we go to the cases, and these are the things that we already mentioned, that when you manage the HHS, you need to ensure you check or inspect the pressure areas because those patients tend to be immobile, they have poor tissue perfusion, and they already have they have background of diabetes, and their diabetes likely is poorly controlled. So there is a risk of peripheral vascular disease as well as neuropathy, which puts them at higher risk of having ulceration. Given dehydration and possibly a background of dementia, mouth care is essential to avoid dryness and mouth ulcers. Eye care, if they are comatose, if they start mobilizing, they are at high risk of fall. So you need to ensure that measures are in place to prevent that. And then they should have nutritional assessment and if deemed suitable and safe, feeding through NG tube and continue hydration until if unable to eat and drink, and continue parenteral hydration as well as IV fluids. Overall, we've already mentioned that. So generally, the complications of HHS, we've just mentioned them, and this is a summary, which is the fluid overload, the high persistent hypernatremia, the hypoglycemia when you overmanage it with insulin without substrate or dextrose cover. There is a risk of neurological complication when you lead to rapid change in osmolality, risk of the AKI that happens from HHS. So you can reverse it with adequate fluid resuscitation, risk of VTE, which we talked about already, and the foot ulcers, which we already mentioned. Good. Ready for the scenarios? Okay.
Yes, yeah, doctor.
I want you to
Before it,
answer me.
so
Yes. Yeah.
yes, there is a question from Dr. Amis. So why there is a risk of rhabdomyolysis in patient with HHS?
Yeah, because as we mentioned in the initial slide of the pathophysiology, those patients present with severe dehydration that leads to muscle injury and release of CK, which and rhabdomyolysis and subsequently high CK levels and which exacerbates AKI. So it's mainly the dehydration, the hyperosmolality that leads to muscle injury.
Yes, crystal clear. So any question so far?
Yeah. Shall we go to the
Yeah,
cases? I'm not
yes,
going to answer
wait
the
to the case.
cases. I want you to answer the cases. Yeah. Good. Let me first just trying to access so I can see your answers. Okay. Good. So read this. Sorry. But again, read the scenario and let me know. So this is a 58-year-old man with treatment-resistant schizophrenia on clozapine and metformin and is brought to the emergency department by his support worker. with 1 week history of increasing thirst, polyuria, lethargy, and worsening confusion. So over the past 24 hours, he has become drowsy and difficult to rouse. His past medical history is schizophrenia, heart failure with reduced left ventricular ejection fraction. He has type 2 diabetes, CKD stage 3, and obesity. This is your initial assessment. His GCS is 9 out of 15. He is obese with a BMI of 41. He is having a lowish blood pressure with tachycardia. His respiratory rate is 22, slightly tachypneic, slightly feverish with a 37.8 degrees. He has dry mucous membranes, bibasal crackles, and mild peripheral edema. These are his labs, ECG, and chest X-ray. Okay. I want you to give me the problem list. So you're seeing this patient. Now you're coming to your differential diagnosis or your problem list before you start management. Any answers? Mhm.
Hello, would you like me to answer?
Yes.
All right, so this patient is quite complex.
Mhm.
But got obesity, CKD, looking at his urea, it's likely AKI and CKD. He's got heart failure of the crackles. His chest X-ray only shows some mild pleural effusion.
Mhm.
But looking at the ECG is insignificant in the meantime. It's a techie with pulses alternance. I wouldn't really worry a lot at the meantime about it. But his labs show severe hypoglycemia,
Mhm.
natremia. We
Mhm.
expect that sodium will find it even higher. Um, yeah, got slightly high potassium. EGFR has decreased. Ketones are detectable, but not over 3, so that's fine.
Mhm.
pH is like slightly acidotic.
Mhm.
HCl3 is decreased, but it's not below 15 or 18. Um, lactate is high. Yeah, we got multiple problems, I guess. It's AKL and CKD, it's hyperglycemia, it's hypernatremia. It's probably HHS. You need to calculate osmolality here and measure osmolality. I would do both. So I would check measured and calculated osmolality.
Mhm.
Yeah.
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 Okay, excellent. Thank you so much. So the problem list, as you rightly said, it's mainly there is a reduced GCS from baseline. There's a hyperglycemia and the osmolality is 362. And there's intravascular volume depletion, which is manifested by the fact that he has AKI as well as lowish blood pressure. And he has AKI on a background of CKD, mild hyperkalemia. And in addition to that, the trigger here is the fact that he's on clozapam, which causes a high insulin resistance. And it masks his clinical deterioration because it's a sedating agent, so, which would already make him drowsy. So he may not be able to mention that he's unwell or he's thirsty or I need to have my blood sugars checked, etc. Good. How would you manage?
So I think we should do an ABCDE approach.
Mm-hmm.
Um, I'm super worried about his GCS.
Mm.
It's 9, I think.
Mhm.
But that would warrant like for the ITU specialist to take a look at him.
Yeah.
Yeah. Furthermore, was his sats was the saturation okay?
What did I say? I forgot. What did I say with the sats? I didn't put it.
Right. Just
Yeah,
much
would assume it's normal with, yeah.
right. So breathing is okay. Circulation looks so well. Where is the capillary refill time and urine output?
I
I'll
would
check.
say slow, seconds.
Oh gosh. And urine output by any chance can we put a 40 in?
Mhm.
So
You don't have it yet. You're just seeing the patient now, so we don't have his urine output because we haven't started the management as well.
so he's definitely hypovolemic by the
Mhm.
capillary refill
Mhm.
and blood pressure. Um, we did check glucose. I'll check for pupillary reflexes and then move on to treatment. This patient is hypervolemic, but there's risk of, this patient is hypovolemic, but there would be a risk of hypervolemia if we overtreat him because of heart failure and CKD. So I'll say we try to admit him to HDU or ICU, and then he has to receive normal saline shoots as soon as possible. Let's start with 250 mils start and see what happens.
Yeah, excellent. So, I mean, the management here, as we said, rightly said, ABCD approach, IV access. You need to give the fluid, like monitor, as well as cautiously administer fluids, potassium, and search for the trigger. Small boluses, as we said, because he's a high-risk patient of fluid overload. He already has bilateral pleural effusions. He has cardiomegaly, and his proBNP is elevated. Because of low GCS, we know it's possibly drug-induced, but we need to rule out a macrovascular event or cerebrovascular event, so we need to have a CT scan for him. And then you need to follow the HHS protocol, cautiously administering fluid because of the heart failure with regular monitoring. And escalate, of course, if no improvement is seen. So these are the main outlines on how to approach this frail patient. Okay? Any question regarding this case before we move to the next one?
Yes, dear doctor. Thank you
Yes.
so much, Dr. Jaffer, for your active participation. So, dear doctor, when do we administer VTE prophylaxis?
Uh, I
heparin.
should have written this. It should be during this management. Yeah. You just give it from the beginning.
Yes, yes. Okay.
An
So,
admission,
do
yeah.
we consider, dear doctor, maybe the intubation is maybe an option here because
If
it's
he doesn't
have got
respond
it's
in the initial,
yes,
it depends. So I'm not sure what's the situation in Iraq. Here in
yes.
the UK, intubation is not a simple decision. So they need to assess the functional status of the patient, his comorbidities, what's his baseline, does he have do not resuscitate form signed already or wishes
Mm,
expressed that we should not resuscitate. Because intubation means that the patient is for full escalation and is for CPR. So this is, yeah, depends on is the patient for full escalation or not. That's
yes,
number
yes.
one. If they are, then we need to if the initial management fails, of course, ITU admission and possibly, yeah, intubation if no
Yes.
response. Yeah, good. If no questions for this case, we'll move to the next case. Okay. So the following case is a real case from last week. And this case was given to me by my colleague, Dr. Araz. This patient was admitted last week to our hospital during the weekend bank holiday time, where these are 4 days of Easter holidays, so there's no specialist input, just on call or out of hours input. So basically, this is an 85-year-old woman who has a background of stroke-related aphasia. She can't talk, so she communicates through writing on a whiteboard. She also has type 2 diabetes, she has CKD, she has atrial fibrillation, myasthenia gravis, and she is on PEG feed. Her social history, she lives in a nursing home. She was sent to the hospital for marked hyperglycemia, which was noted after changes made to her pig feed regimen. Okay. On initial assessment, the patient was alert, not in obvious distress, but very dry. She was afebrile, no history of cough or abdominal pain or vomiting. She was hemodynamically stable. Her chest was initially clear, abdomen soft. Peg tube site was clean, no evidence of infection. And she had a catheter draining clear urine. Her baseline aphasia limited ability to take any history, and her comprehension was better than expression. That means she was able to nod and understand what you say, but of course unable to talk. These are her initial bloods, and this is her ECG. I would like a volunteer to give me the problem list here and what can you find in her blood tests.
So you can unmute yourself directly if you want to answer the direct.
Thank you, Dr. Zainab.
Yes, thank you,
Uh,
Mehdi, for participating.
Thank you. I show in this ECG finding there is absence of P wave and irregular interval. It's most likely it is case of AF
Yeah.
with neurological finding. This is AF and emboli causes embolism. I show the GFR was declined from 50 to 30. There is acute on chronic MBChB. Blood glucose is elevated, hypernatremia. Ketone is low to exclude this DKA, and pH is normal. CRB in the normal range, lactate borderline. This is case of HHS, but I need to calculate the osmolality.
Yes. What made you suspect it's HHS?
Sorry.
What made you think it's HHS?
Level of the blood glucose, hypernatremia.
Excellent.
The sign of dehydrated.
Excellent. Yeah.
And the decline of the GFR.
Excellent. Excellent. Thank you so much, Mahdi. So as you rightly said, the ECG is showing AF, and as we said in her past medical history, she is known to have atrial fibrillation, and she is already aphasic from a previous stroke. This aphasia is not new. So the problem list here for this patient is that she has HHS, which is with osmolality of 361. She has intravascular volume depletion manifested by the fact that she has hypernatremia and she has AKI. She has peg feed associated hyperglycemia. So there's a high carb load through her peg feed, which is not met with adequate insulin. And this is likely the trigger here. Furthermore, she is a frail old lady. She's a care home resident with multiple comorbidities. And what even made her situation worse, that she's aphasic, so she has communication barrier and she's unable to express her clinical status or deterioration or thirst. And she has a background of overall poor diabetes control. I did not put that in the information here, but her HbA1c was above 12%. So there is a high risk of hyperglycemia and recurrence. So, it was too soon. So the way we manage this is we just start hydration, cautious hydration keeping in mind there is a risk of, she's a frail old lady, and she has a background of CKD, so there might be a chance of a fluid overload. So we cautiously hydrate, and then we adequately monitor the changes in sodium and osmolality, as well as urine output and her renal function. So she was managed with the fluids. What happened 24 hours later, she developed hypoxia. She was put on she required 3 liters of oxygen to maintain her saturation. She developed bilateral crackles. She had a peripheral edema, and her fluid balance was 3 liters positive. So clearly, this patient became fluid overloaded. These are her bloods. What can you see? This is 24 hours later after we started the fluids.
Sorry, Doctor. There is increase in the level of the sodium, maybe
Yeah.
يعني excessive correction with normal saline causes
Yes.
hypernatremia,
Mm-hmm.
and elevated the level of the pro-BNP.
Yes.
This is in case of multiple comorbid and maybe cases of the heart failure and exacerbated by fluid overload and the decreased urine output due to CKD lead to this finding. And the case of the يعني, exacerbation of acute heart failure due to fluid overload.
So when you see this, I mean, you saw this patient initially, you started the fluids, you started the fluids, then this happened. They asked you to come back and see this patient again because of these numbers and this clinical picture. What would be the first thing you would do?
First of thing, decrease the fluid replacement
Mm-hmm.
due to the acute increase in the level of sodium, يعني
Mm-hmm.
acute hypernatremia below 24, 48 hour, to prevent exacerbated of the hypernatremia complication.
Mm-hmm. Good. So you noticed as well the sugar has not really dropped despite positive fluid balance. Sodium hasn't really changed, but there is an improvement in the renal function. And now we're dealing with a new thing that wasn't in her past medical history, or she wasn't known to have, which is heart failure that we discovered. So the first thing so what we did the chest X-ray, which, as you can see, showed pulmonary congestion with a blunted angle, which is with an evidence of emerging pulmonary edema here. So the new problem list now we're dealing with ongoing unresolving HHS. There is a fluid overload complicating HHS treatment. There's a new diagnosis of heart failure. There is an intravascular depletion with third spacing leading to hypernatremia. And this is we need to remember there's an ongoing PEG feed that is leading to persistent hyperglycemia. And what happened with this patient, this was not managed. The hyperglycemia associated with PEG feed was not appropriately managed, and insulin was not appropriately initiated. There is a high risk of VTE in this patient and the pressure injury, and ongoing communication barrier, which did not alert the team early on about her clinical deterioration. Plus, she's very frail. So now we are dealing with the initial problem, which has not resolved after the initial fluid resuscitation, and we are dealing with a new complication that happened as a consequence of the initial approach. Good. So in order to address these, that's when the diabetes team was involved in her management. She was commenced on insulin, as you said, slower IV fluid was the new approach was the fluid overload, a slow IVI, and then she is having a peg feed, so we can introduce water via peg very slowly as well. And the water via peg is a free water. It doesn't have any sodium in it. So we need to be careful when we introduce it, not to avoid rapid change in osmolality, but this helps a lot in order to slowly reduce sodium. And we don't, if you have that route or that type of access, you don't really need the half saline in this case. You can give a slow IV sodium chloride alongside slow water via free water via peg, of course, with the close monitoring. And you need to give controlled diuresis. This patient was, of course, diuresed with IV furosemide 80 milligrams. But given the fact that she is multimorbid, there was initial delays or inappropriate management of her HHS. She clinically deteriorated. She did not respond well, and discussions are being made about putting her as an end of life and palliative because given the poor unguarded prognosis. So what went wrong with this case is the fact that there was a delayed recognition of the feeding related trigger, which was the hyperglycemia associated with the feed, and delayed management subsequently of that feeding related hyperglycemia. There is failure to follow the HHS pathway that is appropriate to her multimorbid state or background. And what happened with her was ad hoc management according to the numbers that were coming up rather than following a structured management approach. She is an old, frail patient with multi-organ failure, so there is low chance that she will survive this condition. And there was also lack of early specialist input, which has led to delayed, like prolonged HHS state that's deemed to be irreversible. Any question regarding this case?
Dear doctor, I have one, please.
Yes.
So, regarding her lab test of suspected infectious cause, like maybe I don't know, but maybe like CBC with elevated vitamin
CRP is
C, or
11.
maybe
The
or maybe
CRP was
her general urine regarding UTI. So,
11.
so
They
is
did
there
all
is
of
an
that. I didn't
yes,
include it, but they did all of that. Anything which was unremarkable, I did not put it in this case.
yes, of course. So, but I want to clarify things that this is the bottom line that we all have to go through because before we are reaching this point here. Every
Yes,
basal
definitely.
test should be yes.
Yeah, they have to send, you have to look for the trigger. Triggers could be infection. And
There's
in
precipitating
elderly,
factors, yes.
yeah, elderly may not manifest infection as normal people do because of various reasons. So you need to still, she has a lactate of 2.5. You need to know, is this all dehydration, hypovolemia driven? Is there an infection, underlying
Yes.
infection? So definitely you need to send a septic workup.
Yes. Thank you so much.
Good. Shall we go to the third case? So we have 4 cases. If you have energy to have to sit to finish this, let me know
I
when to
do,
stop.
I do actually. So I think all of my people here actually won't thrive to another one. Yes.
Good. Okay. I'm happy to stop at any point. Good. The third case is an 82-year-old woman with type 2 diabetes treated with metformin and gliclazide. Is brought to you, brought from a care home with 5 days history of reduced oral intake and increased drowsiness and confusion. Staff reported polyuria over the past week, poor fluid intake, and reduced mobility. She is usually able to mobilize with a frame and converse normally, but today she is difficult to engage and intermittently agitated. So now, if you break this down, she is an elderly woman on oral hypoglycemic agents, like most of our patients. And she's a care home resident, and they have reported 1 week history of osmotic symptoms, the thirst and the polyuria, and reduced mobility. And now she came back after that 1 week of these symptoms after she developed acute delirium, difficulty to engage with the team, and intermittently agitated. Her initial assessment, there's a reduced GCS. She is hemodynamically unstable. She is slightly at the upper limit of normal heart respiratory rate, very mild, just a starting fever, not just borderline feverish. She is dry. She has cold pre-freeze. Her right calf is swollen, tender, and mildly erythematous. There is no focal neurology that is obvious on a gross examination. Good. These are her initial bloods and her ECG. Just someone to break down, again, our problem list. When we see this patient, what are we just listing our issues or our problems? Any volunteer?
Okay, doctor.
Mahdi.
Can you please
Yes,
return to the case
I will
just
return
for
to the case for you. Yeah.
time? This is case of old age and history of DM type 2 on metformin and sulfonylurea. Reduce oral intake in old age. First of thing should exclude the risk of infection.
Yes.
Decreased mobility and difficulty to engage. Glasgow Coma scale is dropped. Blood pressure is dropped. This is a very dangerous sign. Heart
Okay.
rate is elevated. Dry mucous membrane is sign of dehydrated. Cold periphery. Right calf is swollen and tender. Mildly erythematous.
Yes.
This is differential of cellulitis, maybe risk of infection, DM, risk of infection, diabetic foot, and also risk of DVT because it's frail and unable to move. No focal neurological finding. This is the
Excellent.
first impression of the case.
Good. And what can you see on the bloods?
Blood glucose is highly elevated. Sodium hypernatremia is a sign of dehydrated intravascular depletion. GFR is dropped. Ketone is negative. pH is normal. This is likely in this is case of DKA. Lactate is elevated, sign of infection. CRB is highly elevated.
Good.
ECG sinus tachycardia.
Excellent.
Differential diagnosis may be HHS exacerbated by infection or DVT.
Yeah, excellent. No, I like your way you broke the case down very well. So this is, as you said, this is a case of severe HHS with osmolality of 396. She is severely dehydrated. Again, AKI, as you can see, AKI is a common theme in all HHS patients. She has raised inflammatory markers, so we need to look for the source of the infection. What's obvious, as you said, is possibly cellulitis, but that doesn't mean we don't take blood cultures, urine cultures, and if she has any skin lesion, we need to swab it. Okay, there's a possibility of DVT, as you said, in the right lower limb, and she is a frail care home resident with a background of poor oral intake and high risk of recurrence. Good. So the way we manage this case is to treat as per HHS protocol with a fluid and hourly monitoring, as we mentioned earlier. Good. As you are managing her, her glucose dropped to 522. Her sodium 167 hasn't really shifted that much, but osmolality is improving. Her blood pressure slightly gone up, and then she is more awake but still confused. Okay, so far happy with this progress to this case? Happy with your patient?
No, doctor. There is increase in the level of sodium
Mhm. Do you remember what
and the
we said
glucose.
about osmolality and sodium?
Glucose is still elevated. يعني should edit the insulin.
Okay, so thank you. So what we said, a rising sodium during HHS treatment is expected. And what matters is usually the osmolality. So if you see, if you go back to the chart from the JBDS guideline, if you remember, as long as you are having adequate hydration, positive fluid balance, and the osmolality is dropping, you should not worry about the rising sodium because that initial rise is expected. If the osmolality is not dropping, you need to reassess your fluid balance and then consider changing it to half saline or hypotonic solution. Okay, so that's the reason why I brought this, just to remember that as long as your osmolality is going down, that means you are doing the right thing. Okay. Okay, before we go, any question regarding this case before we go to our last case?
Yes, dear doctor. Thank you so much, Dr. Mahdi, for your active participation.
Yes.
Dear doctor, I'm asking about how we can exclude pulmonary embolism in such cases, because as we are seeing this case, there is a tachycardia there, and especially in the ECG, there is sinus tachycardia.
No,
And
definitely. So I
you,
just these
so
cases are abbreviated. I didn't pull the full. So DVT should be excluded, as we said in the problem list. So she should have a Doppler ultrasound, and if the Doppler
okay,
ultrasound is negative, and you still suspect there is a DVT, a venous thromboembolism, then you need to proceed to CTPA. If she's still, despite, so when you initially, so she's initially tachycardic and hemodynamically unstable because of the dehydration, but still a venous thromboembolism is high on the differential diagnosis list and should not be, you should not just leave it. You have to work on excluding it by imaging, D-dimers, etc.
oh, okay. So and even adding the VTE prophylaxis there.
Yeah, I mean, in this case, if it comes to me, if this patient comes, this is a very like an imaginary case. This is not a real case. But when I see this case and I see that her CRP is 89, it's not that high. It is high, but not that elevated. But the leg is quite swollen, and if the cuffs are firm, and I feel there's a strong suspicion of her VTE event, and her Wells score is suggestive of that, I would treat as PE or DVT until I rule it out with imaging. You can just give one-off dose of anticoagulation treatment dose, request a Doppler ultrasound or a CTPA if Doppler is negative. That's where I feel comfortable that I have ruled it out and I can just manage with prophylaxis. And this is not DVT, okay? Because sometimes when you do the scan, the Doppler that comes back normal, but there is still this strong clinical suspicion that a venous thromboembolic event is there. That's when you proceed to CTPA.
Thank you so much.
Thank you. So you just go by clinical suspicion and how you feel the case is presenting. Good. Last case. A 61-year-old man with type 2 diabetes on empagliflozin, metformin, and sitagliptin underwent an elective total hip replacement 2 days ago. Postoperatively, his postoperative course was complicated by poor oral intake, nausea, and reduced mobility. Day 2 postoperative, staff noticed increasing confusion and lethargy over 12 hours. Initial assessment, he is confused, opening eyes to speech. He is, again, hemodynamically unstable. And this is a remarkable drop in his blood pressure compared to baseline blood pressure. He is requiring oxygen. He is hypoxic. He is feverish. The surgical wound looks mildly erythematous, but there was no pus and no discharge. His abdomen soft, mild epigastric tenderness noted, and the rest of examination is normal. His bloods, as you can see here. Any volunteer? The last volunteer for today.
Okay, Doctor, I will participate.
Thank you, Mace. Go ahead.
So this is an elderly patient. He is type 2 DM and he was having surgery 2 days ago. His glycemic coma scale is a 12 and he is deteriorating and vitally unstable. Regarding his random, nearly 400, his pH 7.2, HCO2 less than 18. So this is acidosis. CRP is very elevated. The pro-BNP is normal. Urea is elevated, maybe acute kidney injury as well. Potassium borderline. So
Excellent.
is he on insulin during the hospitalization?
No, he's not.
Okay, so I can consider him as DKA, but I have to exclude HHS DKA overlap by calculating the osmolality. But the glucose is normal, less than 600.
All right. Anything else you think is going on with him? What's the trigger in your opinion?
The surgery itself.
Okay.
The decreased oral intake.
Mm-hmm.
Maybe DVT also.
Okay. And what would be the cause of high CRP?
The surgery itself can cause high CRP, but infection most likely.
Excellent, excellent, Mace. Thank you so much. So the problem list here we have, as you rightly said, mixed euglycemic DKA and HHS. Remember, in the history, when I talked about the patient, I did not say that the patient stopped his empagliflozin, which was not stopped. So his empagliflozin was stopped throughout, perioperatively. And we, as you know, with SGLT2 inhibitors, they should be stopped 2 to 3 days prior to any surgical operation, and when the patient is unwell, and should be resumed when the patient is back to their normal baseline. So we know that this acidosis is triggered by the fact that the patient was on an agent that led to this. He has mild HHS with the osmolality of 333, and his DKA is mild. If anyone attended the DKA teaching, we talked about the criteria, and with his current pH and ketones, and the bicarb, he fulfills the criteria for a mild DKA. He has postoperative stress and dehydration, which impacted on his risk of developing the DKA and HHS. Of course, he's having AKI. He is hemodynamically intravascularly deplete with the hypotension and hypovolemia. There is, although we said initially the surgical wound slightly red, but there was no pus and discharge, but this does not rule out the fact that there could be a surgical site infection. And the recent major surgery is also another contributing factor or stress element. He was treated as per protocol for DKA and HHS, and then cultures taken, antibiotics administered, and surgical review requested. Then 6 hours later, his GCS dropped further. His sugar is 180, which has reduced compared to the initial one. His sodium gone up, osmolality slightly reduced. His blood pressure remained low, and his heart rate is his blood pressure and heart rate got worse compared to the initial one. He is now requiring more oxygen. His ketones dropped, lactate gone up, bicarb. So if you look at the numbers, his acidosis has improved, osmolality slightly improved, but his sodium has gone up, and his GCS worsened, his oxygen worsened, and his hemodynamic stability got worse. And now we have a new right-sided weakness, which wasn't present on the initial assessment. Does Mace want to continue, or anyone else can chip in and tell me what's happening here?
I can continue.
Yeah, thank you.
So there's worsening of the classical coma scale, and he's deteriorating. Maybe we'll have CVA here because of the right-sided weakness. But also the desaturation is worrisome. Maybe DVT also with secondary pulmonary embolism. I don't know.
Okay, what else do you think is going on here? Why his blood pressure is getting worse, he's more tachy, and his lactate is getting worse. And his sodium is getting worse.
Sodium is rising.
Lactate is rising as well.
Yes. What about the infection management? Is it okay?
He received antibiotics. Or did he not? We said he received antibiotic and the management. Yeah.
Okay, but what about his lung examination?
His what? Sorry.
Lung examination.
Leg examination.
Leg examination
Neck.
and his chest examination.
Chest is fine. Neck. What's in the neck you're looking for?
Raised JVP.
No, normal.
Okay. Maybe this is pulmonary embolism, massive because of the low blood pressure. Or he has heart failure. We didn't know about it.
Yes.
Do we have the ProBNP?
Did we have it initially? I can't remember. Yeah, it was normal. Yeah.
Okay, so his Gladys score is decreasing. It's 8. Maybe he needs intubation at this point, or to be admitted in the intensive care unit.
Okay.
And we have the right-sided weakness. Maybe this is a new episode of CVA.
Excellent. I like the way you broke things down. We still don't know. You need to have a differential diagnosis list. CVA, of course, definitely need to be ruled out because we have a new right-sided weakness and a drop in GCS, so he needs an urgent CT scan. PE need to be ruled out because someone who is hemodynamically unstable now and become more hypoxic. This is something you need to put it on your differential diagnosis list. Rising sodium should raise despite improvement in osmolality, an improvement in the ketones and improvement in the bicarb and sugars. That means should raise the suspicion that the patient may be intravascularly deplete and there might be some element of inadequate hydration. Okay, I still don't have a new renal function to assess whether creatinine and eGFR are improving, getting worse. I just have this information from a blood gas showing the sodium and the glucose and calculated osmolality. Okay, so what just happened is, could this be a cerebrovascular accident? As you said, there is a worsening shock, rising lactate. So when you see a rising lactate, you need to think about sepsis or bleeding or hypovolemic shock, basically. This needs to be ruled out. So even if the wound looks clean, the patient requires urgent surgical review to rule out intra bleeding, and we need to do another septic workup to rule out undergoing sepsis. So the management here, and it's not added here, but PE or should be added to the differentials here as well. So he had a CT head, surgical review for possible hematoma, and adequately hydrated, admitted, as you said, to ITU for inotropic support, and if no improvement, he may end up having intubation, and then a new set of cultures were sent. The learning message from her, the learning point from this case is the fact that the patient is improving metabolically, but now developing a new neurological and hemodynamic complication. So you need to now reprioritize and shift your protocol or fluid management protocol to address these new complications. Just the point of these cases is when you start a treatment, that shows you that these patients are quite frail, at high risk of having complications. So they require regular reassessment, regular changes or modification of your plan as per the new findings as you reassess and as time goes on. We can't just start the protocol and leave the patient. Okay. And finally, this is just a reference for euglycemic HHS if someone would like to read about it. It's again another emerging medical problem as we are more and more using these agents more widely among type 2 patients. And education is very important for anyone on these patients. Please ensure any patient on these agents, please ensure you educate them about the sick day rules associated with the SGLT2 inhibitors to prevent DKA, euglycemic DKA or HHS when they are undergoing stress or having acute illness. Finally, the prevention strategy is just mainly focused on educating the patients, early recognition of HHS, alteration of medications, and emphasizing the importance of adherence to treatment to prevent hyperglycemia. If patient is demented or unable to express, we should have higher threshold and more close observation about the fact that they might be dry and unable to express this need to drink or thirst. It's important to for care home resident to train the staff to recognize these features and then prevent complications, promptly treat infections, and monitor patients' blood sugars if they are in residential homes, etc. Finally, the most effective treatment is the one that's never needed. Any question?
Doctor, yes, what about feeding, whether the patient is an HHS patient or DKA? Because in Iraq, we have patients admitted in ER for more than 2 days, like 3 days and more. There is a clinical practice to prohibit the patient from eating and drinking to control the chart. And during grading, I didn't find anything clear about the role of the feeding for these patients.
Yes, I mean, I mentioned this in the previous teaching when we talked about DKA. So it depends. There is no clear consensus about keeping the patient nil by mouth while you're treating them for DKA or HHS. So this will depend on your clinical judgment and your clinical assessment. If the patient comes with low GCS, they are vomiting, extremely acidotic, or have extremely high ketones, it's safer to keep them nil by mouth because there will be a high risk of aspiration until you correct the problem you're dealing with. But if the patient comes with mild DKA or mild HHS, they have normal GCS, they are able to communicate, they don't have any nausea, they did not present with vomiting, especially in DKA, you can allow them to eat small snacks or small meals that are not complex, that have simple carbs, because this will help reverse ketosis quickly. And because if you keep them nil by mouth during management, even when they become unwell, if during all that time they are nil by mouth, there will be an element of starvation ketosis here you're dealing with. So if they are safe to eat, no vomiting, then by all means you can allow them to eat small, like simple carb or a small meal or a snack. It's all based on your clinical judgment of the patient, but there's no harm of doing it if you feel it's safe to do that. Safe from the aspiration point of view, not from the fact that they are having DKA or HHS. The whole issue is about aspiration risk. And of course, when they eat, you should match this with insulin. So you need to keep in mind that sugar may rise, insulin requirement may go up. So you need to ensure that you're meeting the rise of that sugar with an adequate insulin. Any other questions? Did that answer your question well, Mace, or is there anything? Did I miss something from what you said?
Yes, thank you, doctor, because this is the common practice. Like 3 days or more, most of the patients will be hungry, and we cannot give anything to them because we have to follow the rules.
But there's no rule. If you read the guidelines, as you said, there's nothing about this. Nothing.
Nothing. There's
Yeah.
nothing clear, but everyone do that, so we have to do that.
Yeah, just again, it's just your follow your clinical judgment, and the main goal is to prevent aspiration pneumonia. So if you feel there is no risk, of course, I mean, I mentioned that earlier as well. Like if a patient asks for a burger or a big meal, you can't give them that. That's just we're talking about a simple meal, like simple carbs, cereal, toast, biscuit, fruit. These are simple things that would not massively impact on the blood sugars and would help reverse the ketosis quickly.
Okay, so complex carbohydrate like dates will work also.
Yeah, simple fruits.
Yogurt.
Yeah, fruits, simple carbs. I'm not talking about burger and chicken and the heavy stuff.
Yes, doctor, thank you.
Jafar, I once had a patient with severe HHS whose glucose is falling, all right, but serum osmolality is not because his serum sodium was not falling, remaining at 165. This was despite giving half normal saline. In such a situation, would there be a role for? Yeah, I mean, you need just to see whether. So the other parameters here is what's his fluid balance? Was it a positive balance, equal balance, or negative balance? If it's negative or equal, that means patient was not hydrated well. And what was the rate of osmolality drop? Was it adequate as per the 3 to 8 milliosmol per kg per hour, or was it a slow drop below that recommended rate? So these factors needs to be taken into consideration. If the patient is able to eat and drink, they have oral fluid intake or free water via NG if they have NG instead of introducing the 0.18 sodium. But if all of the above are done, there are positive balance, renal functions, I mean, osmolality is dropping at the correct rate, then yeah, you can try the 0.18 and see. But that would be interesting to see all parameters were okay with this HCS, GCS. Yeah, I mean, yeah, as long as you're meeting all parameters, everything is going in the right direction, then he may need to have like the extremely hypertonic solution, as you said. And if he's on endotracheal tube, very likely he has an NG. So, and free water via NG is another option here instead of giving the 0.18 sodium chloride. What did they do to him? What happened to the patient eventually? Jafar, if you can tell us.
So he was transferred later, like 2 days later, to another hospital for
Okay.
ICU.
You don't know what happened with him.
Yeah, all I know is that he developed respiratory distress syndrome and died 2 days later, unfortunately.
ARDS, okay, yeah. Is it from too much fluids given?
Not sure, but he had some severe AKI too. I do know that in that ICU, who is managed as hypernatremia, I think hypernatremic dehydration. That's what I know.
Okay, yeah. I mean, as you said, yeah, 0.18 could be considered. 4% glucose as a hydrating fluid should be considered, but you need to keep in mind you need to cover that with insulin as well. And if he's have an NG, free water via NG is another option here. But again, slowly, we don't want a rapid change in osmolality.
All right, thank you very much.
Thank you. Any other questions? Okay.
So thank you so much, Dr. Zainab. Thank you so much, Dr. Jafar, Dr. Mahdi, Dr. Amais, for your active engagement and participation. And before we end, I kindly ask Dr. Amais or Dr. Jafar, Dr. Mahdi, to tell us what are their degrees in the internal medicine. They are senior house officers because we are so happy for for your engagement, and we want to see if there is any improvement added to your clinical practice, not just in this lecture, but in the whole series of emergency endocrinology and maybe our next series, inshallah. Okay, so regarding certificates, I assure all of you before the next session, inshallah, you will all of you received your participation certification through your email. So feel free. So please make sure to address to fill the forms of feedback and as well as the registration form, and we will make sure before inshallah the next session it will reach all of you inshallah. So thank you so much. Dr. Jafar answers. Internal medicine doctor, education fellow in Kufa University. Yes, I'm starting a job as GCSF and Royal. Oh, mashallah. Trust him. Okay, so thank you so much. They're really wonderful. Okay, Dr. Mahdi, medical resident from Iraq, Wasat, MRCP Part 1. Really beautiful. So very high level. Thank you so much. So thank you so much. We are meeting inshallah in the next month, in the end of it, dealing with thyroid emergencies. Hopefully, inshallah, we will have a very beautiful and very beautiful engagement as it's in this lecture. Thank you so much for the thanks extend to Dr. Zainab for her beautiful lecture as always. Thank you so much all. Very happy and have a nice rest of your night today. Thank you so much.
Thank you all. Thank you.
شكرا جزيلا.